Go.
Ready? All right. Hi, my name's Adam. Today I'm going to be talking about hyperkalemia. I know when I started out in med school, this was a daunting topic. I didn't understand how potassium balance can affect the heart and the rest of the body. But I'm going to walk you through the physiology, and then we're going to, hopefully that'll help you understand clinical manifestations, EKG changes, and ultimately we're going to talk about major causes of hyperkalemia and finally the treatment. So first and foremost, we have a cell here, and potassium, greatest extracellular ion, intracellular ion, excuse me, sodium, extracellular. You've got active transport that occurs, 3 sodium against its concentration and 2 potassium. Now, when you have increased extracellular potassium, what happens is you're decreasing this gradient for potassium to leave the cell. And as you remember from the Nernst equation, potassium largely determines the resting membrane potential of the cell. So that's going to make it more positive. Now, if we talk about neuron action potential, here's your normal threshold. You've got your sodium depolarization and potassium repolarization. Now, you're going to make with hyperkalemia, you're going to increase resting membrane potential, make it more positive. Initially, what you're going to get is increased excitability. It's easier to achieve that depolarization. But because of this increased resting membrane potential, your sodium channel inactivation gates, if you remember, they stay closed, and ultimately you get a decrease in sodium channels that are able to depolarize, so you get a decreased amplitude. And because of the increased potassium, you'll also get an increased rate of repolarization. However, over time, because of less and less sodium channels being recruited, you essentially can't depolarize, so that's why you get clinical manifestations like weakness, fatigue, ultimately paralysis, and decreased deep tendon reflexes. Now I'm going to move on to the heart. If you remember, there are 2 action potentials in the heart. You've got your ventricular myocytes and your pacemaker cells. Now, if you remember, there's phase 0, then 1, 2, 3, 4. You got sodium depolarization, potassium repolarization, then you got potassium and calcium going in, potassium going out, and then finally potassium again. And with your SA node and pacemaker cells, you've got your calcium depolarization followed by potassium repolarization, and then resting membrane potential. Well, depolarization is largely determined by it's called funny current. It's largely determined by sodium. Now, specifically, potassium balance affects ventricular myocytes a lot more. And the way that it does that is, again, you're raising your resting membrane potential. So it's initially easier to polarize. So you're going to decrease the amplitude of your depolarization. And then you're going to increase the rate of repolarization. Now, on an EKG, what that's going to look like, let's draw it over here. You got your normal EKG here. You got your normal PR, P wave, QRS, and T. And with hyperkalemia, with the decreased amplitude, that's going to prolong QRS depolarization. So that's going to result in widened QRS complexes. And with increased repolarization, you're going to get these tall peak T waves. And also you can end up also getting prolonged atrial depolarization, your widening P. Now, peak T waves are always the first EKG manifestation of hyperkalemia, and later on you get prolonged P and QRS depolarization. And a sign of imminent cardiac problem, either you can go to VFib or asystole, is what we call sinusoidal EKG waves. So at that point, treatment is imminent, or death is imminent. You need to treat. Now, some of the things that can affect potassium balance, let's review. Magnesium is a cofactor for this sodium potassium ATPase. So if you decrease magnesium, essentially you're not going to send potassium back into the cell, you're going to get an increased extracellular potassium. Also something like acidosis. Your cells and your body always wants to stay in homeostasis and maintain a neutral charge. So when there's lots of acid outside the cell and you want to correct that and send acid inside, you try and temper that with some potassium, so that can increase potassium outside of the cell. Other major contributors are your, if you remember, your renin, angiotensin aldosterone system, and aldosterone increases sodium retention and increases potassium excretion. So if you have a low aldosterone, you essentially can retain lots of potassium. Other major causes of, so those are the major causes of potassium, the major factors playing a role in potassium balance. However, the major causes of a disrupted potassium balance are things like renal failure. If your kidneys aren't working, you're not excreting potassium. Other things that can disrupt this balance are things like drugs, ACE inhibitors, angiotensin receptor blockers, things like penicillin G, several antibiotics, and non-depolarizing, depolarizing muscle blockers like succinylcholine can also affect these things. Other things that can affect this are things like large cell damage, so large crushing injury, or things like tumor lysis syndrome. Also, I didn't mention before, things like beta-adrenergic receptors activation can cause potassium to shift into the cell, as well as insulin. Which brings me now to treatment. First and foremost, when you have a potential life-threatening arrhythmia occurring, you need to stabilize the cardiac cell membrane, and that's why you give calcium. Calcium can compete for sodium, and so what that does is prevent further depolarization. Next, like I mentioned, insulin and beta agonists like albuterol cause a shift of potassium into the cell. Another one that is less commonly used is sodium bicarb, and that's relating to acid-base status. And last, you want to bind that potassium that's in the blood, and you do that with a chelator called Kayexalate. So that concludes my talk. If there are any questions, I'll leave it open.